In this video, we'll talk about giant cell arteritis, or what we call temporal arteritis, how we approach it, and how do we treat it. So giant cell arteritis, as we mentioned in the previous video, it includes large vessels. Now, one important thing to know about it, it can present acutely or subacutely. So don't always imagine that giant cell arteritis, they present in acute setting. They can have the symptoms for weeks before coming to you. Now, the symptoms we're talking about is headache 70% of the time, which is the most common symptom, followed by jaw pain, which is around 50% of the time. Then we have the most feared complication, which is vision loss. And you need to differentiate what do we mean by vision loss here. The patient won't complain of blurry vision. They will have visual field loss. And when you examine them with the fundoscopy, you don't necessarily find any abnormalities there. 15% of them will have permanent vision loss, and this is the reason why we have to treat these patients before even diagnosing for sure that they have temporal arteritis, because treating them with steroids can help decrease this percentage significantly. Part of the history, you want to ask about if they have any pain in their shoulders, thighs, or hips, looking for the presence of polymyalgia rheumatica, which is present in around 50% of the patients with temporal arteritis. Now, one important thing is the age. It's unheard of or very unusual to have patients with temporal arteritis who are less than the age of 50. So this is very important in differentiating this disease from many other diseases. Now, based on the history, you will think this patient has temporal arteritis. Next, you want to do physical exam. Look at the temporal artery. If it's prominent and red, then that goes with temporal arteritis. You can feel it as well. The patient might have tenderness on palpation. The next thing is you want to check the pulses, and the reason there will be a difference in the pulses in the upper extremities because these patients are high risk for developing thoracic aortic aneurysms, and this makes them higher risk for aortic dissections as well. Then you want to look into their eyes with the fundoscopy, and remember that they might have normal appearance of the retina despite having acute vision loss from the temporal arteritis. It might be helpful to rule out other diseases with the fundoscopy as well. Now, how do we diagnose temporal arteritis? So to make it simple, we need the 3 out of the following 5. You need a new headache, fever, and visual loss. Then you need someone with the age above 50, and you need temporal artery tenderness, as well as ESR elevated, and positive biopsy or color Doppler ultrasound, which is equivalent to a biopsy if the operator is doing it properly. Now, some comments here. I would say age above 50 is almost always present, and you need to pick the other 2 from the other 4. And as you can see, you might have 3 positive from these 5 without having positive ESR, nor having a biopsy to confirm your diagnosis yet. So after you having 3 out of these 5, you can start a treatment right away. Now, most of the time, you will need to confirm your diagnosis with doing a biopsy to make sure you are treating the right diagnosis. Now, after you have these positive 3 out of 5, you need to treat before confirming the diagnosis. Now, if the patient has visual changes, then these need admission to the hospital and IV methylprednisone. If they don't have any visual symptoms, then you can just treat them with PO prednisone, 60 milligrams, and taper down. And make sure to consult emergently ophthalmologists who can help you with the diagnosis as well. Now, one important thing is to notice, after you start the steroids, these patients have quick response, and within 1 or 2 days they will start to have feeling much better, their vision is better, and their headache is much better. Now let's discuss what if you start the patient on a 60 milligrams PO because they don't have any visual loss, After 2 weeks, normally you should start tapering down to 40 milligrams, and after another 2 weeks, you want to taper it down to 20 milligrams. Now, while they are on the 20 milligrams, they started to have symptoms again. What would you do? Would you start them back on the 60 milligrams or put them back on the 40 milligrams, which was enough for them to control their symptoms? And the answer is you put them back on the 40 milligrams, which was their lowest effective dose, and you want to taper it down this time at a slower rate. And this is very high yield. They like to ask about which dose you want to put them back if they have their symptoms back again. Now, what if steroids fail to control the symptoms? Then we have tocilizumab, which is interleukin-6 inhibitor, as a second line. And you need to know that TNF-alpha inhibitors don't have significant effect in these patients, as well as methotrexate. It might have some effect, but it's not significant enough to prescribe it to these patients. So tocilizumab is the second line in these patients if steroids does not control their symptoms, and this is the way you will approach or treat these patients. Hope you guys learned something. See you in the next one.